All right, class, we are going into another drug here today. We're going into Ipratropium bromide, or better known as Atrovent. And Atrovent is a lot easier, quicker to write, and again, that is the trade name for it. But but a lot of the times we're going to see Ipratropium bromide, and this is our other medication that we usually give with a nebulized treatment. And so let's go over this just a little bit and talk about some of the pros and the cons and when you use it and when you don't use it. Again, the trade name is usually Atrovent, so usually we usually say albuterol Atrovent, and again, it's just easier to say, and that's usually why we do it. But again, you got to know that other name. So a couple things you need to know for trivia night, again, is reversible bronchospasms with COPD, including chronic bronchitis and emphysema. So your COPD patients, even your asthmatics, it works pretty decent on. And it's a parasympatholytic, so it stops the parasympathetic system. So our albuterol enhances the sympathetic system. The atropine, the Atrovent actually inhibits the parasympathetic, and so it's kind of like a double whammy on, especially with the lung tissue, because it helps really open up that lung tissue. And again, it is chemically related to atropine, so it's kind of got all of its bad side effects, if you will. As we know, we use atropine for speeding up heart rates for bradycardic patients in a sinus rhythm. So obviously, you can pretty much guess that this drug speeds up the heart rate, and we'll talk about that here when we get to the side effects of it. So again, it's an anticholinergic. And again, it's a bronchodilator agonist, so it's going to help open up that lung tissue. Again, it dilates the bronchioles, especially when they're really tightened down. So it blocks that rest and digest process, and it makes the bronchioles bigger as a result. Okay, so now, again, your atropine derivative is used for an inhalation therapy. So again, it's basically, it comes from that belladonna plant, and it has many of the same attributes as that. So it's used in the treatment of respiratory emergencies, and again, relaxes the bronchial smooth muscles, and blocks acetylcholine receptors, thus inhibiting parasympathetic stimulation. So in other words, it doesn't let the parasympathetic system come in. So the only thing left is the stimulated sympathetic system. So it does increase in intercellular GAMP, and again, a lot of times when they give this, and there's some debate about this one, they give it. There's some services that give it right off the bat. They give albuterol Atrovent on the first one. There's other services that go albuterol, and then you can go albuterol Atrovent. I think both of them have their merit, and the reason why is that, again, I think giving a patient more medicine than they need is a bad idea. But I will also tell you that this stuff takes 15 to 30 minutes to work. So if you wait and the patient's having trouble breathing, and you give them a breathing treatment, and the albuterol is not enough, then you've kind of delayed that patient from breathing for 15 more minutes. And that's why I think it's kind of not really. Again, there's a lot of factors involved. If they're really tachycardic, I will hold off on this drug. But again, this guy right here, it takes 15 to 30 minutes to work. So therefore, both cases have merit, and I think it is situationally appropriate. And the good thing is it lasts 4 to 6 hours. Now, my other favorite thing that I love hearing is a paramedic goes, well, I gave the Atrovent, and so I'm just going to give him another Atrovent. And it doesn't work like that, okay? It just does not work like that. So, again, it usually lasts for around 4 to 6 hours, and really only one in the pre-hospital setting is all you're going to need to do. Again, when you get into the doctor's office, they may say, or in the hospital, they might do it every 2 to 3 hours, and that's to get a cumulative effect to help the patient breathe easier. So sometimes it is done. Now, again, it's used as a supplement to albuterol in patients with asthma and COPD. And again, it's when they're unresponsive to albuterol alone, that's when we'll give it. So a lot of the side effects of this, again, tachycardia is your big one, and we already talked about it with albuterol. Tachycardia is a side effect, so you're kind of hitting them with the old double whammy with that one. The other thing is it will send blood pressure through the roof, so keep a close eye on that. You might have some problems there. Again, don't give it to a glaucoma patient because, again, it does increase intraocular pressure. If they got any type of eye injury where there's increased intraocular pressure, stay away from it. Again, it can give your patient a headache as well, a little bit of blurred vision. That is normal. It'll give them a dry mouth, just like the albuterol will. Pharyngeal irritation. You can get some coughing. You can actually cause bronchitis by giving this drug, and you can increase their dyspnea a little bit initially. So until they kind of open up, it can cause a little bit of a rebound effect. So again, if they got severe narrow angle glaucoma, do not give them Atrovent. Don't give it to them, okay? If they're the soybean peanut allergy, it really doesn't apply. And the reason that I say that is they weren't allergic to the albuterol or the Atrovent. They were allergic to the materials that was used as a preservative. And so a lot of paramedics you might hear say, well, if they have a soybean allergy, we can't give them Atrovent. That's not really true. Again, if you can get away with not doing it, I would say do it that way. So again, there's very few interactions other than just remember it accumulates the effects of the albuterol, so it kind of helps that out. And again, usually when they're having wheezing, that's kind of what we want. And again, it's usually administered with albuterol. And again, just be careful when you're giving this patient to people with heart diseases or high blood pressure. If they're elderly, remember that they're a little bit more sensitive to this. And they block the rest. When we're talking about it, it actually blocks that rest and digest mechanism. If they're on certain drugs, by the way, that can be potentiated of that. If you can get a peak flow, obviously we usually don't get that. But again, the peak flow meter is a spirometer where they blow into it and they see how much they can actually move. If you can get that, great. But again, I don't think any of us usually carry those on our ambulances. So it's usually a 0.5 milligrams or 500 mics and 2.5 of normal saline, okay? And then we usually administer it with a beta agonist, whether it be albuterol or Xopenex. Xopenex, by the way, what's Xopenex? Xopenex is like albuterol and steroids with none of the side effects. Well, Scott, why don't we use Xopenex? Well, the reason we don't use Xopenex is because albuterol is like $1 a fish, and Xopenex is like $25 a fish. So that's usually why they don't have Xopenex. Now, again, your adult dose is 0.5 milligrams and 2 mLs. Again, make sure, double check your fish here, gang. Double check to make sure. Matter of fact, what I used to do is I would take my black marker and my Atrovents, I would actually rub over with a black marker so you could actually read it. And I knew that if I saw the black marker that it was probably not albuterol, but it was Atrovent, and we needed to use that. Again, for kids, if they're above the age of 12, we can use it, and we just use the adult dose. If they're below the age of 12, we usually don't give the Atrovent to them. Just go with straight albuterol. We don't use that for the pre-hospital for the little kids. And again, we only give this by nebulizer. We don't give this IV. We don't give this pouring the fish down the ET tube. We just don't do it. Pregnancy, it's actually really safe to give to the pregnant ladies. So again, the category B on those, the albuterols are C, those are B. I've used it in pregnant patients before. Just keep an eye on the heart rate. That's the biggest thing you got to do. All right, well, that's going to end it for the Ipratropium. We'll see you next time.